I'm Dr. Erin Elliott.
And I'm Jason Tierney.
I'm a dentist.
And I'm a dilettante. And we're going to talk about sleep matters because
sleep matters.
Jonathan Lown, Dr. Jonathan Lown. How are you?
Good.
Great.
Thanks for having me.
Yeah, Erin and I are jazzed that you're, well, I'm speaking for Erin. Erin, you're pretty happy.
I'm jazzed too,
right?
I'm jazzed too, yes.
Yeah, jazz hands. But Jonathan Lown, I got to tell you, one of the smartest people I know in sleep medicine, Scott Craig, told me many years ago, Dr. Jonathan Lown is the smartest person I've ever met. And I thought, well, Scott's a pretty sharp guy. So if he's saying that about you, that's saying a whole hell of a lot. So we're thrilled that you're here. And why don't you just tell us a little bit about kind of who you are and how you got here?
So I do internal medicine. I do sleep in Long Island. And we've been doing this for over 15, 20 years now. And excuse me, I'm also a sleep apnea patient, and we've definitely focused our practice on trying to improve overall sleep in patients. But not only that, but also understanding that CPAP is not the only approach. And so we've had a partnership with Dr. Arthur Feigenbaum. I've been working with him for a long time now. So we do oral appliance therapy, and I think we do a pretty decent job of trying to get patients to, meet their goals and improve their overall quality of life. And I think it's a really exciting field also because every year, every couple of years, things keep exploding. And there's some new stuff that we're all excited about.
Yeah. So what's the most recent explosion that's got you excited?
So definitely the GLP-1 inclusion and the approval by the FDA for Zepbound for OSA, I think is a huge leap forward. I think there's definitely a huge unmet need. And there's also other things that are coming down the pike. There's actually some cool insomnia brain stimulation devices, or one device, the Modius, is coming out. And there's also actually eventually going to be a medicine for sleep apnea too. But I think right now the Zepbound miracle, I call it. I've actually been on it myself, so it's really helped immensely. I think what's interesting also is I really was a little delusional about my own weight. I mean, I'm looking back at photos, and I think that's the most revealing. You don't realize how overweight you may be until you really see what you look like in a photo. And I would be counseling patients and, asking them to lose weight, and I wasn't really doing it myself. So I kind of stuck at about 230. Now I'm at 185.
Wow. I would say having that weight loss conversation with patients is not the easiest, especially when you look like me. But joking. I did 8 years ago. Right? Yeah, no, 8 years ago, I did lose about 30, 35 pounds and have kept it off. And that was, of course, before medications and that sort of thing. But I feel like every woman I meet in sleep where we do an appliance and it's doing the best it can, I said, really the next thing we can do is, positional therapy, add a CPAP or weight loss. And I said, just 5 pounds. Like, don't think about 50 pounds, just 5 pounds. I learned that from Kent Smith, just so they get these small wins. I think of 30 pounds as like 3 10-pound bags of potatoes I was carrying around. And, it does give you a new lease on life. But the medications have just made it more attainable for people. And I tell them it may not cure your sleep apnea, but it's going to reduce the severity. And then, of course, there's those people that say Zepbound for sleep apnea. There's a lot of skinny people that have sleep apnea. It's not the miracle cure. But I said, I think the biggest deal about that is people want access to GLP-1s and they are paying out of pocket right now. But because Zepbound is approved FDA approved for sleep apnea, if you have that diagnosis, insurance has to cover it. Is that kind of
it's true,
some of the politics of it?
Yeah, Medicare is still not really covering it, but private insurances are for sure. And the problem is you're absolutely right. There's about at least 20-30% of the population may not be particularly overweight or obese. And it's hard to totally generalize what was shown in the OSA SURMOUNT trial because the BMI was on average about 39. So it wasn't like they were just above, 30, but the FDA still understood that it's such a, important thing that they did get approval for just a BMI of 30 or higher. And the question is there going to be much benefit if you put somebody on it, or if you could put somebody on it if their BMI is less than 30? And we really don't know that. There's some suggestion that when you get down that low, that's probably more anatomical issues that you're kind of born with or have developed, but not necessarily soft tissue. So nobody really knows that for certain, but you're right. I mean, I think there should be access, there should be better access, and this is definitely expanding access a lot, which is great. It's not like it's for everybody, and a lot of patients would say, well, why did you have to be on it? And I said I was honest with myself. It's not like I don't know what to do in terms of diet and exercise. I do. It just was out of my reach, or at least I could plateau. And now it's changed really how I feel. I mean, last night I didn't get a great night's of sleep, but other than that, most nights I feel, like I get actually even better sleep, and my energy is tremendous now. It's not only what you said, Erin, and I totally agree with you that it's like you're carrying 30 pounds of, potatoes all the time. It's also all the increased inflammation you get from fat cells. From adipose is really like a factory of inflammatory cytokines. So you feel better. And that's what really was also shown. The quality of sleep in the tirzepatide study, the trial 1 and 2, which were without patients who didn't want to be on CPAP and those who wanted to be on CPAP, they both saw benefits in their quality of sleep and on daytime level functioning. So it really does help. I mean, we all should be pushing patients to get down. And as much as those BMI cutoffs seem kind of strict, they're very accurate, I think. Unfortunately, BMI of 24.5 is really technically normal. I still have patients coming in now who've lost a significant amount of weight, and the spouse will say, oh, I think my husband or wife is too thin now. And it's hard to kind of re-educate people and say, well, no, that's actually really what you want to be. It's really the lowest rate of all-cause mortality. So everything is lower when your body mass index is lower. So it's really
on that
overall good help.
On that point, Jonathan, a few years ago there was this sort of craze that swept the world, this healthy at any size. So, and Erin mentioned how challenging it can be to have those conversations. I mean, how do you broach this topic? And especially when you're met with some kind of objections from patients, how do you navigate that and sort of help them see the light?
Yeah. So again, I usually will show them that graph, the all-cause mortality association, which is very robust. In fact, if you took out smokers in the all-cause mortality data, it's actually flat, because people sometimes will still argue if your body mass index goes too low, your all-cause mortality starts to go up. But it really is, if you take out smokers, it's flat. Now, granted, if your body mass index is less than 19, there's probably something else going on there. It may not be so good. But I try not to hammer them with it, because I think most of us sort of understand that it's probably better and you'll feel better. I hear you. I think we sort of tried to stop shaming people and saying it's, their fault. But if you really do look at the data, the majority of us, I mean, you two are sort of in the minority, and it's a good thing, because I know you folks are very disciplined in terms of diet and exercise, and that's amazing. So I never discount that. I always tell patients, if you can get there. In fact, literally before I just got on, I had a conversation with a patient who has sleep apnea, who definitely has had actually a cardiac intervention. really should get his weight down. And so we offered it again. And he's like, no, I want to try it on my own. I say, I'm not telling you can't do it. I think most of us can. It's about maintaining it. So most of the data is that patients are going to continue to be overweight, even though, they make multiple attempts, sometimes as many as 10 attempts in their lifetime. Mm-hmm. And that's the other thing that I don't know how much time we really have to talk about this specifically, but a real revealing study was the SURMOUNT-4 trial. So in SURMOUNT-4, they had patients initially on Zepbound, they lost weight, and then they discontinued about half of them to see what happened. And only about 18% of them were able to maintain weight by the end of the year, but the majority of them regained weight. And
that's what I was going to ask you.
Yeah, so about 60% weight regain happened by the end of the year.
I think people were so frustrated about diet, and there was always the women I talked to have tried for 30, 40 years, right? And so that's, I think, to Jason's point, when people started saying, well, let's just celebrate being bigger because it just seems like a futile attempt. But this really has given people the opportunity. And I think one of the biggest advantages it has, and I'm sure people are telling me, like, no one should be on it, there's going to be long-term effects, but right now everything looks pretty good. I feel like obesity has long-term effects as well. But the food noise that is limited, it's not that constant thinking about food, and food becomes more of like fuel for your body versus a reward center or, emotional. Saying that, the people you put on Zepbound, are they usually on CPAP and then can get off of it and maybe move to like an oral appliance if there's any remaining, or do they have no treatment at all while they're losing weight?
So going back to the food noise comment, I think that's very astute. And I would say that I heard that message over and over again from patients about food noise. And I always thought I didn't have any food noise, and I sure did. And I was pretty good. I'm still doing intermittent fasting, which I really like, and I feel amazing doing that. But the problem was when I wasn't busy and working, like on a Sunday, it's like I was going to the chair. I would eat an insane amount of food, go out to dinner, I'd order everything. And I realized I did have food noise, and I was being a little delusional. So I think it's very hard. It's very hard to stop that. We have, a zillion years of evolution where, if you think about what Darwin said, most organisms on the planet are going to die from either being eaten or starvation. Yeah. And that's definitely true of human or humanoid populations. So we have all these systems in place to make sure we're not starving. So you're kind of fighting, you're really swimming against the tide. I think that's very hard for the average person. And then there's the argument, as we get older, our metabolism does seem to slow down. There's some debate about this. I think some of the data isn't probably correct, because it was a couple of years ago, there was a very interesting study that said our basal metabolic rate doesn't actually drop until age 60, which is probably nonsense. But so what I'd say, I can tell you from my own anecdotal experience, is that when I was younger and I was thin, I was very thin most of my life until about age 35. I really started gaining weight, but I could eat like a horse and never gain weight. In college, not to really go too far into the weeds, in the cafeteria, I would literally eat the food on the tray and then go back and start over again. That's how much food I could eat. I could eat an entire loaf of bread. I never gained any weight. So it gets harder and harder. If you're not keeping your muscle mass up, it's really difficult. And then obviously all the other things that we have to deal with. But you're absolutely right. It's also a reward system for us. So, most of the time we don't realize how strongly tied into us feeling better eating is.
Yeah, because one of the comments I hear too is, oh, you'll lose muscle mass. But I'm like, well, are the people taking it, were they not that active before and haven't incorporated some activity of weightlifting and that sort of thing? So they need to adapt some healthy habits still. even
Right.
even with just a shot.
So that's unfortunate. It's kind of like, listen, I'm not going to tell you it's the best thing since sliced bread and there's nothing better, but just to step back, I didn't answer the comment you made.
Oh.
Is that it's been, so GLP-1s, that class of drugs has really been around for it's going to be 21 years now. I think a lot of patients don't realize that. So we used Byetta way back when. It definitely led to some weight loss, just not as dramatic. So that's one. Two is we have now between semaglutide, which is Ozempic and Wegovy, and tirzepatide, which is Zepbound and Mounjaro, we have over 30,000 patients. It's not like it hasn't been studied. It's been really well studied. There's really no signal. You don't want to ever be cavalier about medicines. You're absolutely right. We don't know the long-term effects. But I think a lot of the concern is sort of gone away. And we did have weight loss drugs that we used for years and years. We didn't really even have outcomes data on it. We just assumed they were safe, and some of them weren't safe. But to go back to what you're saying about the muscle mass, that's true of any weight loss. So we've known that for the last 50 years or so, especially from bariatric data. If you can Google this, look up what happens to the percentage of muscle mass that you lose from bariatric surgery. It's significant. And the more dramatic the weight loss, the more dramatic it is, that muscle mass loss. And it's not because people aren't necessarily, trying to stay up with being active. I think that's an absolutely important thing. You're absolutely right. Doing any kind of weightlifting, even push-ups, sit-ups, planking, I tell patients, if they're not used to doing anything, and being more active, especially now that you're lighter, is an imperative. But unfortunately, it's a little bit inherent in potentially any weight loss. And one of the reasons is we don't have a way to partition. It's not like our body says, you know what, I'm only going to remove calories or get calories from fat, and I'm not going to take anything from muscle. It doesn't happen. So we definitely can see muscle loss from any significant weight loss. And it is much more dramatic with these drugs because the weight loss is so dramatic. But, and I don't want to be cavalier about it. The cool thing is that the muscle mass reduction hasn't really led to a blunting of the positive effects, though. The reduction in blood pressure, the reduction in insulin resistance, all these other things have really not been blunted by that reduction in muscle mass. So that's sort of a good thing. But you're absolutely right. If you can maintain muscle mass, it's even better. I do think people have to watch how much protein they're consuming. And if you step back from it, it's
because they're typically not consuming enough.
Right, because they're consuming less calories. So if their diet is more rich in carbs, they may not be consuming enough protein. And so there is some data that if you increase your protein consumption, you may somewhat blunt that reduction in muscle mass.
Okay.
Not the most robust.
Do you keep them on like a low dose when they're done so they don't have rebound weight gain?
So I don't necessarily stop their dose, or it depends on how they feel. We usually try to tailor it down if they can tolerate it, not so much tolerate it, but if they don't have an increase or a bump in their weight, I'll usually keep them on the same dose. I'm currently on 7.5, and 7.5, I'm going to probably stay on it for a while. I don't know what I'm going to do in the future in terms of reducing it. But I know a lot of patients are like, oh, I got to get off of it. And the problem is that, that's why I brought up the, SURMOUNT-4 trial, is that it really is a significant number of patients are going to regain weight. And it's not like they couldn't maintain it. It's just very difficult. It's
old habits.
Yeah.
I don't know. I feel like it's a new lease on life. And I've seen people like,
I'm sorry about that beeping, by the way.
Used to be couch potatoes or hiking. And like they do get a new lease on life and they'll go back to just sit in the chair still. And it's because they feel better, sleeping better.
Well, John,
I did
real quick. Sorry, I'm curious about this. I mean, Jonathan, you said you've lost in total, around 50 pounds?
Yeah.
Yeah. You mentioned you have more energy, but I mean, how do you feel? Sorry to dip in your diary here, but I mean, mentally, emotionally, how are you feeling?
I feel really good. I mean, really feel good. It's kind of crazy. I'm much more energized. My focus is much better. My attention is better overall. Like I said, I think everything really improved, including my sleep quality improved. And I definitely would dip. That one of the reasons I was doing intermittent fasting is I found that I had better energy during the day when I would do that. Now I have like a tremendous amount of energy being this much lighter. So I know it's frustrating for patients to, think that they have to be on a medicine. And I'm not necessarily saying they have to be, but we have to be pragmatic too about it. Because
one more thing real quick, Aaron, I'm sorry.
Yeah.
Jonathan, if we go back to, you mentioned, seeing these photos and sort of the delusion, what was the impetus to really take action and make these changes?
Well, so one of the things that happened was also my blood sugar, my hemoglobin A1C started going up. So that was one of the problems, but it was also, every now and then you do kind of catch a glimpse of yourself. And it happened a long time. For a while, many, many moons ago, I actually did Body for Life. And one of the clever things about that book was to take a photo of yourself in a bathing suit, like Speedo, and put it on your fridge. And it's frightening to see because so it was some of that, like just looking at photos and saying, what the heck, that's me? Like you sort of don't think about it. And especially because every single day I'm counseling patients, and I'm sure to some degree, patients are like, who is this guy delusional? He's got to lose weight. So it was a combination of things. I have a pretty strong family history of actually diabetes on my father's side. So it was definitely a concern that my numbers were going to continue to go up. And we sort of have data that probably in hemoglobin A1C of 5.4 is probably where we should mostly be. It's not like everyone is going to get there. And so I was going way above that. So I wasn't practicing what I preach. And that I think really sort of hit me. And truth be told, when I first started on tirzepatide on Zepbound, I was on 2.5 and I was on 5. And I'm like, I don't need to go up. I'm good. And I really wasn't good. I'd get my weight down, the weight would go back up. And then for some crazy reason, 7.5 just clicked with me. And that's when I really started losing the weight. So I was pretty plateaued for a long time. So I don't know if I answered that question there, Jason. But
Jason has his own weight loss journey as well. So we should post our before and after for the show notes.
Is incredible.
Yeah, we really should. Jonathan, if you don't mind, shoot me a photo after this.
I want the Speedo version.
I want the Speedo fridge photo.
Wait, hold on.
And I forgot that I did ask a two-parter. So what do you do for treatment in patients? Like, do you use things in conjunction? I've had a lot of patients coming in for oral appliance because once they lost weight, CPAP didn't work for them as well. I'm assuming they still have some, if it's anatomical residual sleep apnea, and that does open the door for oral appliance therapy when the severity comes down.
Yeah, no, absolutely. I think that's an exciting part of that. We've definitely have shifted some patients from who are, CPAP patients to oral appliance therapy, especially because of the weight loss. And that's the other point I'd say about trying to maintain the weight, because, you get them an oral appliance. If they theoretically had a significant residual AHI in oral appliance therapy and were on CPAP, we obviously want them to maintain the weight. So we've definitely done that. And I'm excited. We're probably going to be doing a lot more of that over time. It's also about what their comfort level is. If they're pretty happy with CPAP, even if they lost the weight, I'm not initially going to change them. But the only problem with, we don't have absolute data yet, but it makes a tremendous amount of sense that that's probably where we're going to be heading. Even the Inspire patients, we have a handful of Inspire patients that haven't really succeeded that much. And we know that the data, if you look at their 5-year follow-up data, their residual AHI was about 12. So it's not super low. Doesn't mean patients don't get really low on Inspire, but I think this is going to be exciting for those patients too. But that's why I think it's so important to talk to the dental sleep community, because I do think this is a great adjunct. And I think we also should be, more comfortable with the idea of even recommending it. Now, I would understand they obviously still have to probably have communication with their physician. But I think if the sleep dentist gets, has some schooling on this, I think that's only good, because there are some little tricks that I kind of wish Lilly, taught everybody. And one of them is really moving out to go. I don't know if I fully answer your question, Aaron, but I'd say this is a great opportunity for that, exactly for the reasons you're stating, is that you still have to keep the airway open. And there's probably limited benefit of continuing to get their BMI down really into the, closer to ideal BMI. We don't really have tremendous data. What we know is that there's a relative association between the percentage of weight loss and the percentage of reduction in the HI. So like in the Surmount OSA trial, it was about a 3-fold factor, 2.5 to 3.
So 10% body weight loss, 30% reduction in AHI.
Exactly. So that works when your BMI is on the higher end, and it still seems to work kind of heading closer to 2, but we don't really know when you're lower than BMI of 30. The presumption is that those are patients who are probably going to have some benefit from it, but that's obviously where the oral appliance could be a tremendously good fit, and same with Inspire. So I do think it's going to open up the door for, patients that may have been either reluctant to do it, or their sleep physician may have been reluctant to recommend it. And now it seems like it should make a tremendous amount of sense. And
well, I know we don't have a ton of time with you because of your busy schedule, but as Jason said, I remember you coming onto the scene and I was like, who is this guy? A sleep physician that actually knows about oral appliances and like will talk to us? What kind of brought you into our world a little bit?
Well, what happened originally was that I was all, gung-ho about CPAP, and then shockingly realized that a hell of a lot of patients are either not compliant or will stop using CPAP. So that's when, way back when, I convinced Dr. Feigenbaum to actually become boarded. And he initially was reluctant to do it. He didn't think it was really worthwhile. He didn't really know anything about oral appliances, which is interesting. So we're glad we did it, because I do think we both learned from that. And that really also changed my opinion, because it's nice to have somebody that you can talk to about the ins and outs and some of the pitfalls or some of the successes that we've had. I wish more. We still have
reluctance from sleep physicians. So how can you?
So that's maybe again. So listen, I think we have to be honest that a significant number of our patients, at least 30% of our patients, maybe more like 50% of our patients, are not going to be compliant or poorly compliant. And we're really not doing them any service. And we want to remember that the joint guidelines, which was 2015, stated that it didn't matter what your sleep apnea degree was. It was really if you couldn't tolerate or preferred oral appliance, you couldn't tolerate CPAP, preferred not to use CPAP, that oral appliance was recommended. And so we don't want to forget that. I think we're still delusional that we assume that everybody's going to be, tolerating and do well with CPAP.
And those are the people that actually go see you. We're kind of more in the trenches of people that are like, if I have to wear a CPAP, I'm not even going to pursue it.
Right. And then a lot of patients obviously would come in, and not that I love all therapies that, a patient can utilize and be successful with. So along the lines of Inspire, we have a tremendous amount of patients initially that came in and said, I heard about Inspire, and then they realize it's 90 minutes of surgery. Now it's superficial surgery. It's not really big anatomical changes, but that sort of changed immediately the opinion about it. So we obviously have a huge unmet need still. And that's why I think we really should be embracing this, because it'll potentially bring a lot more patients to your door. And, maybe if we ever have another opportunity to talk about this, obviously, if everybody can show up in Arizona, that'd be great too, because we can talk more details. But I do have some tips or tricks how to get patients to be more tolerant of, Zepbound or GLP-1.
Yeah, let's hear them. Can we just hear? Can you just enumerate kind of the bullet points, and we can spend more time on them another conversation?
I think the big problem is that it's kind of like when we put patients on cholesterol lowering medications, and they would have initially like a drop in their cholesterol, and then it would kind of start to rise back up. And the reason is because they just assumed that the medicine was taking care of the dietary component, and they didn't really have to change their diet, or they could go back to kind of a poor diet. And so it's the same thing. I think we need to be aware that these drugs are very powerful. One of the things it's definitely doing is turning the stomach into like what we call a food depot. So we really want to be careful about when your cutoff time is for your last meal. I think that makes a huge amount of difference. I think reflux can definitely be kicked up if you don't do that. We usually our cutoff is 7:00 usually for patients if they can help it. Just be aware that if you overeat, you may not feel so good. And I can't tell, I didn't really go through all the times when I felt horrible on this drug, because there were some times I felt horrible. And then the other thing I think we sort of aren't really pushing patients is being regular with their bowels. I think it's really, really important that they're regular with their bowels, because we do have data, and it's old, it's like from the 30s, that the more you distend the colon, the more you can get upper GI symptoms. You can get queasiness, you can get like agita, you can get bloating, you can get even, frank belly pain. And it's not from the stomach. I think when we think, oh, you have nausea, you have belly pain, you have bloating, it's only from the stomach. It's not necessarily from the stomach. It's from the colon too, because the sort of reflexes go back and forth. A quick example is the gastrocolic reflex. So when you eat a meal, most of us will have, especially in the morning, after we eat, we'll have this urge to move our bowels, and that's called the gastrocolic reflex, because when food goes in the stomach, impulses go from the stomach to the colon to tell the colon to kind of get ready. Even though it may take 24 hours for that food to get to the colon is already starting to kind of move things along. But the reverse happens. When you have a lot of distension in the colon, it can really slow down the bowel and slow down your response. So it can make you feel pretty lousy. And I think we haven't been pushing that. So now I'm very strict.
Literally haven't been pushing it.
Yeah, exactly. But so the thing I say is that I really tell patients, even if they think they're moving their bowels, they're probably still not moving it, because we don't have a scale in our toilets, right? So it's not like how much stool you pass every day, and it has to be a certain amount. So we have this kind of poor assessment of how much we're passing, whether we're really constipated. So you can have a bowel movement every day and still be very constipated. So that's one of the things I tell patients. And then hydration is, everybody talks about hydration, but it's really, really important when you're on these medicines. I think it makes your life easier. If you feel better, it makes it much easier in terms of, being on it and being successful. And because unfortunately, we still have some patients who will not change their lifestyle. I have 2 patients who are on 15 milligrams and literally haven't lost a pound. So, which is really hard to imagine, but it happens.
Got it. So let me ask you, I know you've got patients, you're busy today. We appreciate you taking the time. I've got a couple of quick questions for you to kind of summarize, and then we've got the final countdown, which is our version of a lightning round, okay? So my question for you, or questions for you, is this. Everything you've shared today, for listeners who are probably largely going to be dentists, but for listeners that hear all this and they go, so what? Why does this matter to me? And then now what? Meaning specifically, what action should I take as a result of this today? How would you answer that? So what? Why does it matter? Now what? Where do I go? What do I do?
So what we have to accept is that these patients who have untreated sleep apnea still have significant increased cardiovascular risk. I think what was interesting about the OSA SURMOUNT trial is one of the reasons why they did the trial with both PAP users and non-PAP users was to make sure that nobody came back and said, well, you know what, you only did it on non-PAP users. If you gave them CPAP, it would have worked as well. And so that argument is, obviously has been dispelled because we looked at both populations, which I think was kind of brilliant. At first, when I heard about it, I was like, that's kind of weird. But so what you can see is that things got a lot better. So blood pressure got a lot better. HSCRP got a lot better. Hypoxic burden got a lot better. And that's really an imperative. We don't want to ignore that. If we're treating these patients, we want to try to help them not only obviously have better sleep and better energy, but also potentially live a better quality of life and live longer if we can, have less untoward effects from sleep apnea. So I think we have a very exciting opportunity to really improve the whole gestalt here, which we didn't necessarily, because obviously some patients on CPAP still could be very overweight. And granted, we got rid of their apnea, but we didn't really lower their blood pressure. We didn't do all these other great things. Maybe we improved hypoxic burden with CPAP. We didn't necessarily improve all these other things. So I do think it shows that we really want to improve their weight. So I think that's, if we're treating them for sleep apnea, we have to bring that conversation up. As painful as Aaron said, I know it is sometimes. You want to try not to be accusatory or shaming, like we said. But I think overall, if you're thinking about your health, and there's obviously you care about your health if you're using any kind of device. So that's one part I'd say that we should be familiarizing ourselves with these drugs, because there's going to be others that also are doing this. And then the other thing I'd say is just reading that article. If you can go online, there's definitely a free version. Sometimes New England Journal actually will allow you to do the free version. You just have to sign up for it. I do think everybody should read this study to at least get an understanding of what they did and how they did it and some of the results, because patients are going to ask. And, I think it's very cool because we've talked about this many times. There aren't enough sleep physicians, period, to handle.
Sure.
If it's really 30 million, at least 30 million, it could be as high as 50 million Americans with OSA. We have a real, practitioner problem. We need to have everybody able to at least have some conversation about it. And then I think the other thing is it may also allow, again, maybe I'm delusional on this one, but maybe it will allow the conversation between the sleep dentist and the sleep physician to open up again, because I think things kind of got soured for whatever reason. And I think it's a great opportunity to say, well, listen, I want you to go back to your physician or your sleep doctor and say, maybe you could reconsider being on, Zepbound, and see how they feel about it. Obviously, try to find a practitioner that's amenable to that. Mm-hmm. Because it's not like it's one and done. You obviously have to still have follow-up. It's not like there are no untoward side effects. But one other quick thing I forgot to mention, I just thought of, is I usually insist that patients get an ultrasound of their belly, because what we know with rapid weight loss, and we've known this from the bariatric community, and by the way, I have a couple more minutes. It looks like this patient actually didn't show up yet. But so what we know from the bariatric community is that when you have rapid weight loss, you'll increase cholesterol excretion. Cholesterol excretion can increase your chance of a gallstone, because gallstones are cholesterol stones. So I usually insist that they get an ultrasound, because if they do have gallstones, I usually put them on ursodiol, which is an old therapy that we learned from bariatric surgeons, because you want to really try to avoid pancreatitis. So there were 2 cases of pancreatitis, and not a lot, but it's something to be aware of. And along that line, I think there's also like some weird reports about like diabetic retinopathy worsening. We've known that diabetic retinopathy, particularly in diabetic patients, obviously, if you drop their blood sugar rapidly, it can increase their chance of having a worsening of diabetic retinopathy temporarily. But the first thing that patients come in is sort of absorb some of the negative rhetoric. And I've even had nutritionists tell patients, don't go on this. I mean, I have a guy who's morbidly obese that's being seen, has been seen by a nutritionist who keeps telling him not to go on it, which is kind of really, it's really kind of unconscionable to say that, especially when we have so much good data.
Yeah. My parents would likely benefit, and I've encouraged them to talk with their doctor about this, and they finally did. And my mom came back and said, the doctor doesn't air quotes, believe in it.
Mm-hmm.
You know, I don't know.
And they're going to take his word over you, Jay.
Sure. Right. Yeah.
Yeah. And it is surprising. And the cool thing, not to, say that AI is the best thing ever, because AI definitely makes some mistakes, sometimes a lot of mistakes, but you really do have the opportunity. That's what I tell patients. I say, well, you know what? Don't take my word for it, even though I'll show them. I kind of have a printout where I'm showing them all the clinical trials. Ask AI what it thinks about these medicines. And that's the cool thing. It's been so well studied now, it's kind of hard to argue against it. Now, I understand it doesn't necessarily mean everybody has to be on it. And I would love patients to be able to do what, like, Jason and Aaron have done. That's awesome. I couldn't do it. I mean, your story is very dramatic, Jason, which is incredible. But unfortunately, it's in the minority of patients. And I also would say that I'm more likely now to do more exercise. I have so much more energy. Like, I just went on a ski trip and it was awesome. It was so much fun because I'm in such better shape now.
Sure. Yeah. Everything gets better, right?
Yeah.
Yeah. So that patient is going to show up. I know you've got to go. You've been very generous with your time already. So we want to kind of wrap up here, but we want to play a little game with you called the final countdown. All right. So you've got less than 15 seconds. Yeah. So you've got you've got less than 10 seconds to answer each of these questions. Are you ready?
Yep.
You sure?
I think so.
All right. Have you ever been fired from a job?
Yes.
What happened? 10 seconds.
I was a little delinquent. It was a bartending job at a golf club.
I feel so that was your Caddyshack moment in real life, right? All right. What about what's the worst movie of all time?
Well, I may actually take flack on this one, but Cobra?
That's Stallone. Well, wasn't he also in the hit Stop or My Mom Will Shoot?
Oh, yeah.
He may have been, yeah.
Yeah.
What was the arm wrestling movie? Over the Top or something like that.
Top. That's what it was. Yeah, I think they were like arm wrestling for custody of a child or something like that. All right. What is the most uncharacteristic thing you've ever done?
Wow.
Do you mean like jump off a cliff, Jake?
Well, I mean, unless he's, that's something he typically does.
I'm just.
Wow, that's a good one. The worst thing I ever did, I shouldn't admit this publicly, was actually getting pretty drunk at a restaurant and then somehow falling asleep in the restaurant where they closed the restaurant.
Okay.
That would be uncharacteristic, yes.
If money didn't matter, what job would you have?
This one.
Love it. Do you like tapioca?
I do, actually.
Same. If you had your own theme song, you're entering the ring, what would that song be?
I still think it would be Adventure of a Lifetime. I love that song.
It's a jam. All right.
Hey, this is like, what's his name? Lipton. Remember Lipton from...
Yes. Yeah.
Have like... Hey, I think he had also like the most odd swear word.
Well, here, give us that one in closing.
So I forget who said it, but like their favorite swear word, and one of the, was it Alec Baldwin? I don't remember who it was, but he said ass bag.
Let's bring that back, Dr. Lown. We're bringing it back.
Not only did Alec Baldwin say it, but so did you. So from one ass bag to another, Dr. Lown, thank you for joining Aaron and I.
Awesome. Keep up the good work, guys. And we'll
appreciate you.
See you soon.
Sleep matters.